Okay, great. Thank you very much. Assalamu alaikum, everybody. I am really, really privileged to be here at this time. Congratulations to all of you for making this happen and during very difficult circumstances. It's 10:30 in New York, but despite the late hour, I'm really excited to be here. Thank you to Dr. Harshem, Dr. Nilofer, and Dr. Rahman for extending the invitation. So my topic today is to discuss the variants of aortic stenosis and to see whether it really makes a difference in prognosis. We're in the era of TAVR, and so I think this is an important thing to discuss. As everyone knows, this is an old slide, Jane Braunwald's, taken from Braunwald, which basically shows the natural history of aortic stenosis. As we all know, it's a disease of the elderly. There's a very long latent period when the patient is completely asymptomatic. There's increasing obstruction, myocardial overload, and all of a sudden the patient falls off a cliff. They're the onset of symptoms, and this is a very, very steep decline when you may have angina, syncope, and heart failure. And these obviously carry very reduced survival. For angina, it's roughly 5 years, for syncope, 3 years, and for heart failure, only 2 years. And so when you're at this stage, you're contemplating about what to do with the patient, you're balancing these kind of statistics with the risk of sudden death, 0.5% per year, the risk of surgery, 1%, and the risk of a prosthetic valve. So when a patient is symptomatic, it's pretty easy to decide that this patient must be referred for either transcatheter aortic valve replacement or surgical aortic valve replacement. Now in this talk, the classification of aortic stenosis severity is very well understood. And we're not talking about these categories in this talk. We're not talking about sclerosis or mild or moderate aortic stenosis. We're talking about severe aortic stenosis, where we primarily rely on the peak velocity, the mean gradient, and the aortic valve area. And these categories are very clearly delineated here in order to make our determination as to what to do. So the reason peak velocity is a respected parameter is because it is directly related to outcome in a very sort of easy fashion to understand. As the peak velocity increases, you see that over a 3-year span, the likelihood of becoming event-free is very less. It really, really goes down. And in fact, Catherine Otto's data suggests that only 25% of patients with severe aortic stenosis will survive or will be really event-free at this point in time. So speaking of Catherine Otto, this is a very seminal study that she did in 1997, and yet there are many, I think, lessons that we can take from this. Once again, this is velocity and outcome. You can see that the 4 meters per second, which is sometimes we regard as a holy grail, is because the 5-year survival, pretty much all of these patients will not be event-free if their velocity exceeds 4 meters per second. However, this data importantly shows that these patients that we often see in the echo lab between 3 and 4 meters per second also do not have a very benign prognosis. Approximately only 20% of them will go on to have event-free survival over this 5-year period. It's only the patients where the velocity is less than 3 meters per second that we can, 85% of them will not have events over this period of time. So you can do some watchful waiting in this scenario. So again, the velocity is actually a marker of disease chronicity, and that's why it's respected so much. You can also talk about the mean gradient, which is another indicator of disease chronicity. And here, of course, we know the well-regarded criteria of greater than 40 millimeters of mercury mean gradient as being a demarcator of patients who will get into trouble. But here you also have another category of individuals where the gradient is extremely high. That is, the gradient is over 60 millimeters of mercury. They fall into a special category and a very high gradient. And these patients actually have a poorer prognosis in this kind of scenario. And finally, the valve area, of course, is also reflects disease chronicity. And it's easy to see here that patients with a lower valve area will get into trouble much earlier than patients with either mild to moderate aortic stenosis. Of course, the rate of progression is highly variable, but the often touted figure is 0.1 centimeters squared per year. And so that's something that has to be borne in mind. Now, it turns out that the valve area is less important when the velocity is high or very high. So in individuals where the velocity is 4 to 6 meters per second, it really doesn't matter what the valve area is, whether it's greater than 0.6 or less than 0.6, their outcome continues to be poor. So we all know that there are inconsistencies in echocardiographic criteria for grading the severity of aortic stenosis. So the reason for these inconsistencies, there is a rough correlation between the mean gradient and the calculated aortic valve area. However, it's rough and there are many inconsistencies. Again, I'm not talking about the inconsistencies that you see with cardiac catheterization, where there are phenomenon of pressure recovery and so forth. But here you simply have a situation where the flow that is directed across the aortic valve does make a difference in the calculation of the valve area. So the flow is something that one has to really bear in mind. So when you look at the hemodynamic classifications of AS, severe AS, these are all patients that have valve area less than 1. You can actually come to 6 gradient flow categories of aortic stenosis. Those with normal flow and either very high gradient or high gradient. Then you can have a high gradient, low flow situation. And then you have those with low gradient where the flow can either be low or the flow can be normal. And the definitions of very high, as I told you before, is greater than 60 millimeters of mercury. The high would mean that the mean gradient is greater than 40. And of course, something that we should be calculating in all our patients is a stroke volume index, because it is not exactly the same as flow, but it is correlated with flow. So the stroke volume index is something that we should be calculating in all our patients. So let's tackle the first couple of criteria, the first couple of categories where the gradient is either very high or high, but the flow is normal. So this category actually turns out to be the most prevalent category of anywhere between 40 and 70%. These patients tend to have more severe aortic stenosis. They have a longer exposure to this disease because their velocities are higher, the gradients are higher, etc. However, there is no, the longitudinal function is preserved in these individuals. So there really is no even subtle left ventricular dysfunction. They're able to generate these high gradients. The BNP, as you can imagine, is higher, and the cardiac event-free survival is reduced. Now, when they become symptomatic, our cath colleagues are, often very gradient dependent. They really want to know what the gradient is. So because their gradients are high or very high, they tend to be referred for AVRs, whether it's a TAVR or a surgical, because they're easily recognizable. When they're asymptomatic, then you need to do further risk stratification, perhaps with stress echocardiography, etc. But again, these patients are usually caught pretty early on and referred for the appropriate management. Now let's look at the second type of category where the flow is actually low, but the gradient is high. And I'll show you an example of that. So this is a patient, parasternal long axis view, where I think you can appreciate that there's good ventricular function overall. There's severe calcification of the aortic leaflets. There's also severe mitral annular calcification, which goes hand in hand. The short axis view at the papillary muscle level and apex shows, again, good ventricular function. The ejection fraction here is normal. The short axis view here shows a highly calcified aortic valve, which barely opens. So, and here you would imagine that the flow is normal, and yet you don't have an aortic valve that opens. Here you've got the patient with severe tricuspid regurgitation. Dr. Parashar was telling us about right ventricular dysfunction. Well, this is a patient where the BNP has been very high, and it's affected the right side, so much so that you have severe TR. And you also have at least moderate to severe pulmonary hypertension. This is the TR velocity. So you've got very high, you've got pulmonary hypertension. In looking at the apical view, you can see that both atria are dilated, again, showing you that this patient is operating at high left ventricular end diastolic pressure. The ejection fraction, however, tends to be normal. So when you actually do a CW Doppler of this valve, you'll see that the Vmax is extremely high, over 6 meters per second, again, falling into that very severe category. And the mean gradient is 19 millimeters of mercury. I think this is like one of the highest gradients I've seen in my career. And the maximum gradient is over 150. Now, you would imagine that this patient, since the ejection fraction was normal and the contractility, at least visually, seemed very good, you would expect the stroke volume index to be normal. However, in this individual, the stroke volume index you see is 32, which is actually kind of low. It turns out that the LVOT diameter in this patient was actually fairly normal. So you cannot really blame it on just not calculating the stroke volume index correctly. So this type of high gradient low flow aortic stenosis, the prevalence of this is much lower. And these patients actually do have subtle ventricular impairment. They have depressed longitudinal function. If you did strain imaging, you would probably be able to detect that. And they can have a preserved ejection fraction. Their BNP does tend to be very high. They have significant left ventricular remodeling. They do become symptomatic soon, particularly since their gradients are high and there is ventricular impairment. They have either the same or actually worse prognosis as those patients with high gradient normal flow aortic stenosis. And they certainly have a better survival with AVR. Again, these patients are picked up early. They usually don't slip through the cracks because their gradient is high. So they recognize fairly early on. So now let's concentrate on the low gradient scenarios where the gradient can either be low due to a depression in ejection fraction, which is the classical variety, or the ejection fraction can be normal, which is the paradoxical variety, and a third category where you have the low gradient, but the flow is normal. So in this kind of scenario, you have an aortic valve area less than 1, a mean gradient of less than 40. So this qualifies as low gradient AS. If you then consider the left ventricular ejection fraction, if it is depressed, you have the classical variety of low flow, low gradient AS. Here the ventricle is dilated. This is a ventricular problem to a large extent. And of course, the low gradient is because you have low flow. Now, in the situations where the ejection fraction is normal, that is greater than 50%, the next thing you can do is calculate a stroke volume index to see whether the stroke volume index is low, in which case this is paradoxical low flow, low gradient aortic stenosis. You notice here that these patients tend to have small hearts. They tend to have very hypertrophied hearts. The reason for the low flow, low gradient may be that they have some form of ventricular impairment. That should be contrasted against those individuals where the stroke volume index is normal and you have a normal flow but still low gradient. So we'll discuss this in the end. Again, let me show you an example. So this is a patient where the parasternal long axis view, you clearly see that there is impaired ventricular function. This anteroseptum is hypocontractile. Again, on the short axis view, you see that this whole area of the septum is hypocontractile. And if you look at their Vmax, you see that it's in that intermediate category between 3 and 4 meter per second, Catherine Otto's category. The mean gradient does not quite meet criteria for high gradient, so this is low gradient. And if you calculate the stroke volume index, you see that the stroke volume index is very low. So this is a patient clearly with low stroke volume index, despite the fact that we use a fairly normal left ventricular outflow tract diameter. You know that this category is, this is something obviously influences your calculation of the stroke volume index. And I just want to make a point here that the flow is actually not the same as stroke volume index. The flow takes into consideration the ejection time. So this is actually just a measurement of how much blood is flowing through the aortic valve per unit time. And in this individual, this is actually a low flow. So the normal flow is approximately 250 milliliters per second, and here the flow is reduced. So it's important, once again, to calculate this in all of your patients with low gradients. Now, if you give this patient dobutamine, as we did here, 5 micrograms per kilogram per minute, you see that the LVOT VTI did increase from 16 to 19. So this is a surrogate of actually stroke volume index. So this is actually what I follow when I give my patients dobutamine. I just keep going till the LVOT reaches a maximum. And you can see that this increased 18%. And if you give more dobutamine, now at 10 mics, you see that there's no further increase in the VTI. So in fact, you can get a less of an increase in stroke volume. So this is what I use to do it. And there's no magic. You can even go up to 15 mics or 20 mics of dobutamine as long as you achieve that maximum. And this is important because what you're trying to calculate is this patient's response to the dobutamine, and a recalculation of the aortic valve will say that this patient falls into the true aortic stenosis category. But is that really the case? This patient's recalculated aortic valve area came out to be 0.8. However, the stroke volume, the flow across the aortic valve only increased from 193 to 203, and the stroke volume index really didn't increase very much. So what you can do in these situations is actually calculate an aortic valve area projected at normal flow rates. You have everything that you need when you're doing a dobutamine stress echo. You have the aortic valve area at rest, you have the change in aortic valve, you have the change in flow, and you have the resting flow. And if you calculate that, you see that the flow just increased only 5%, and yet the calculated aortic valve area comes out to less than 0.8. However, this situation, this is really valid only if the flow increases by at least 15%. So in other words, you need a certain amount of flow, a certain amount of oomph, if you will, to open up these aortic valve leaflets. And even if you do a TEE in these individuals, to look at the planimetered valve area, you can be off because, again, you need that certain amount of flow in order to keep things open. So this, again, just highlights the use of dobutamine stress echocardiography to calculate the flow reserve. And if the flow reserve is normal and you get a high gradient and the valve area calculates to less than 1, then you have true severe AS. If the gradient, on the other hand, remains low, and the valve area is actually more than 1, then you have really just a ventricular dysfunction scenario with pseudo-severe AS, and heart failure treatment would be the most appropriate response. Now, what do you do in this individual that I showed you before, where the stroke volume really did not increase sufficiently and it was less than 20%? So here you don't know whether this patient really has severe AS or not. So in this scenario, there is a role for determining the calcium score. And there are different values for calcium score, whether you're a woman or a man. And this actually correlates with the physical amount of obstruction of the leaflets themselves due to a piling up of calcium. And so that is something that we do use in those patients with diminished flow reserve, and you want to make the case that they should be intervened on. The one other parameter that I want to impress on is calculation of global left ventricular afterload or valvular arterial impedance. Now, everybody knows that aortic stenosis is a disease of the elderly. So in addition to having obstruction at the level of the valve, you also have obstruction after the valve. In other words, the afterload may be high due to vascular stiffness because the patients are elderly, or you can have systolic hypertension that is causing this global LV afterload. So this is a double whammy for the ventricle to sustain. It's facing a double scenario. So you can actually calculate this impedance by looking at the systolic arterial pressure, the mean pressure gradient, and the stroke volume index. And we routinely do this. And you know that a value of the global afterload, if it's more than 5, that's associated with a poor. However, what I should impress upon is that this global afterload itself is a flow-dependent parameter. And you see that in low flow states, a very small change in stroke volume will actually cause a big change in this global afterload. So it is less reliable in low flow states. So that's something that has to be borne in mind when you're doing these calculations. So in terms of the low gradient, low flow aortic stenosis, whether it's the classical variety or the paradoxical variety, the prevalence, you can have patients who are asymptomatic, but most of these patients are in fact symptomatic. Here you have more pronounced LV.
Dr. Aasha, we have 1 minute time left.
Sure, I'm almost.
Yes, yeah.
You have a smaller LV cavity, you have increased global afterload, and in these patients, the prognosis is very grim because these patients actually are misdiagnosed. The severity of AS is often underestimated. And if that's the case, then they're not referred, or AVR is usually delayed. So again, the class 2A criteria for these patients is actually to refer them for surgery or a TAVR. So the last category is low gradient normal flow aortic stenosis. And I just want to finish this by saying that this is actually just simply put, when the flow is normal, this is a scenario where there's just less severe aortic stenosis. This is a shorter exposure to this disease. So this patient actually has a better prognosis compared to the other categories. And therefore, it's important to see whether the symptoms are actually due to aortic stenosis itself or they're due to other comorbidities. So in conclusion, again, the low flow scenarios are the ones that are the most difficult to sort out. And the butylamine stress echocardiography, calcium scoring, and calculating the global LV afterload is again very helpful in sorting these patients out. Thank you very much for your attention.
Professor Sabina, go ahead.
Thank you, Aasha, for joining in our conference and delivering an excellent presentation. And now the floor is open for discussion. I think, Nilüfer, there is a question. Can you please, for Dr. Parashar, can you please?
Dr. Ahmed Mamunul Haq asked Dr. Parashar sir, can we classify RV dysfunction into mild, moderate, severe based on the echo parameters? Dr. Parashar sir.
Yeah, because depending upon what parameters you are taking, say they have been labeled mainly on the what are the values you get. So we are mainly concerned with severe and mild. Moderate comes in between also. So if you take any value what we have given, the lesser the value, the more severe is the disease. Whether it is a TAPSE, whether it is systolic velocity, or whether it is the other things also. So the lesser the velocity, the lesser the value. For example, in a ejection fraction, if it is less than 20, it means it is almost a severe aortic stenosis. So they depend upon, you can say, but mostly we are only saying that the RV dysfunction is present. When you are sure, then you can say that yes, it is moderately deranged or severely deranged. For example, the one picture I showed, that was a severe associated, severe thing by visual impression also. So whether you do, so yes, you can say that whether it is a severe RV dysfunction also, depending upon how less are the values.
Okay, thank you, sir.